Fantastic. All right. So look, evening everyone. Hope everyone is well. So evening Manchester. Just heard that you guys are going to tier 3 lockdown. So happy days ahead. Ali, how you doing, buddy? You good?
I'm good. I'm looking forward to this lecture. Like I said, I was telling the guys, Niji, Owen and Sam earlier, that normally Dr. Jin will pump himself up and have a black coffee to get himself all going, and I had helped myself to a cheesecake factory cheesecake, okay, Oreo one and a strawberry one. So I'm all ready to go. All good.
Fantastic. First, look, thank you to Sam, Niji, and Owen for the invitation and for organizing such a fantastic thing. I mean, it's a good way of keeping everyone connected, keeping the education going, and connecting the whole dental community. So well done to you guys for what you put together. And again, the full support from us guys, from the Academy as well, for all the lectures you do in the future. So when these guys approached us to do a webinar today, myself and Ali sat down and said, how can we really tailor make it so the undergrads, whether you're in second year, third year, or fourth or fifth year, can get the most out of it? So today we're going to take on a journey through minimally invasive aesthetic dentistry from our eyes and how we see it as well, and something called the FAST approach as well. So as Niji said, we do run the Smile Dental Academy and have won various awards. And myself and Ali have been teaching for 10 years now together. So Ali's our 10-year anniversary. Happy anniversary, buddy.
Happy anniversary as well, Jen. It's, you know what, I can't believe 10 years have flown by. Yeah, it's just flown, literally.
And we thought the best way to present today is by going through a case. So this case we're going to go through, some of you guys, fourth and fifth year, may be able to keep up with the case itself. Some of you guys in second and third year may pick up on a little bit. So I'm going to show you the whole case write-up. So you'll be even learning how we write up our larger cases in practice. So you might pick up a little bit of information from today's lecture webinar. If anything, any questions, again, drop it in the chat box, ask us, and we will get those questions answered as well. These guys have said we've got an hour, but again, look, we're flexible. We will tailor make it to however you guys want to go, and we're going to go with the flow today. So any questions, drop it in the chat box where Niji has written something, and we will answer it as well. So what I want to do, guys, is introduce you to Steve. Steve is who we're going to be discussing today. He is one of our long-term patients who I've been seeing for a number of years. And when he first came to see me, Steve was super anxious. First saw him nearly 8 years ago. And when he first came to see me, he wanted something done with his teeth and he wanted them looking better. And this is where the concept of minimally invasive aesthetic dentistry started for me.
And for me as well. I mean, I hadn't done one, and thing in our practice is we all work as a team. Okay. And one thing we've come to realize is that 2 heads are better than 1. Wouldn't you agree, Jim?
Totally. And a lot of our cases we routinely discuss them together. Once a week, we take a lot of photographs, and the patients that way will get the most out of it as well. Because we all know, we put a case up today, every dental school, every professor, every academy.
Jin, you're breaking up.
Can you hear me now?
Yeah, we completely paused for a minute.
Sorry.
So every dentist.
That's right. Every dentist, everyone will do the case differently. So when we sit down and discuss it, it's best to get every option and present it to the patient as well. So Steve is 56 years old. Well, actually, he's gone over 60 now. It's been a while now. He is a construction manager.
He's 64 or 64, I think now.
And he's unhappy with the look of his teeth and wants them looking better. History of presenting complaint is no current pain at all. And medical history-wise, he's fit and healthy with no known allergies. He's a smoker, so smokes 20 cigarettes for the past 30 years, so 30 pack years, and 5 units of alcohol consumption per week. Now, Steve here is a very irregular attender. He last went to the dentist 5 years ago for some pain. Hasn't been since, had a bad experience, and he's coming in today for his teeth to look better. Oral hygiene-wise, he brushes well. He says he uses fluoride-containing toothpaste, but he's never used any interdental cleaning or mouthwash as well. So again, you guys are seeing how we go through our case assessments as well in practice, and this is exactly how we document it as well. Diet-wise, he's not a frequent snacker or excessive sugar. And habits-wise, his wife has told him he grinds his teeth. So I see the family and his wife goes, look, Steve, you grind your teeth, go see Jin. It might be a reason why your teeth have worn down. So then we went on to the extraoral examination. So Steve is a skeletal class 2. We checked his temporomandibular joint, which was normal. There's no symptoms. We checked for clicking, for crepitus, or any deviation when he opens the jaw. We checked his muscles of mastication, which had no tenderness. He had no lymphadenopathy, or no evidence of facial swelling as well.
And now, just on that note, guys, I mean, I'm sure you know, if you don't know how to check for tenderness of muscles of mastication, it's a massage on the outside, having a feel of the joint, but then you get your thumb, okay, and place it on the inside, okay, right near there. Put your thumb inside the mouth and massage with the finger outside. And if that's tender, that means they are grinding or clenching as well. So that's how you check muscles of mastication tenderness.
And we checked his symmetry. We had a midline center shift to the right by 2 millimeters. Then we went to check intraorally, and this is Steve presenting. He wants his teeth looking better. Intraorally, we checked the gingivae, floor of the mouth, tongue, buccal mucosa, palate, and there were no abnormalities detected. And again, I document this in the notes as well. We went into a periodontal examination, oral hygiene being moderate, checked for bleeding on probing, which he did at a couple of sites, and we did a BPE score. We also did a plaque score after disclosing tablets, and he had a plaque score of about 75%. And something which I routinely do is check his tissue biotype. So Ali, is that something you do as well?
Yeah, absolutely. I mean, biotype is basically how thick, in simple terms, how thick is the gum? How thick are the gums? Have they got thick gums or thin gums? Okay, so I struggled with this concept for a while, but in simple words, that's what they mean by biotype. But yeah, it makes a difference, because if they've got thick biotype, that means you can cut the gingiva, you can burn it, you can do a lot of stuff with it, and it'll recover quite well. If it's thin gingiva, okay, and the way to tell if it's thin gingiva or thin biotype is if you put a probe there and it blanches. Okay, so with the perio probe, anything you do with it, if you cut it, if you damage it, or ill-fitting temporary crowns, and the tissues will start receding.
Fantastic. Then we went on to the occlusal examination. Now, do not get too worried about the intricacies of the occlusal examination. We are going to break it down for you guys later on. As I said, there's a lot of information in today's lecture, but we're not going to go through too much detail in terms of every part of it. But my fundamental stuff I look for in occlusal examination is this. So Ali, do you want to go through this?
Yeah, absolutely. So we are looking at what the incisal relationship is. It's class 2, div 2. What that means is class 2 is when your top incisors are forward. Div 2 means they stick back. Div 1 is when they stick forward. Okay, in simple terms, protrusion is anterior, we're checking the anterior guidance. Now, this is, I just want to break down some terminology here. Okay, protrusion is, if I turn sideways, pushing your jaw forward, okay? So bite your teeth together, push forward, that's protrusion. Okay, so I will ask you all to do that. And if you've got light, even contacts at the front and no back teeth touching, you're good. Okay, that's ideal. Okay, but if you've got back teeth touching, then that can cause problems if you ever need a full mouth rehab on yourself in the future, God forbid. Lateral excursions is when you put your teeth together. Okay, bite normally, not like patients. Patients bite edge to edge. We want you to bite normally, okay, and push your jaw to the left. Okay, and if only your canines are touching, your canine guidance. Okay, and if any of the back teeth are touching, so if the 4s are grinding or the 5s are grinding when you do this, okay, then you are group function. Okay, so that's what the terminology means. Easy to manipulate into RAP. RAP is retruded arc position. Now the thing with occlusion is that there are tons of terminology, and a lot of them mean the same thing. Okay, in simple terms, okay, to start off with, they are slightly different, but just group them together. RAP, RCP, so retruded arc position, retruded arc of closure, retruded arc, the retruded contact point, centric relation, all mean the same thing. Okay, all the same thing. It depends which dental school you go to, which tutor you're talking to. They have their personal preference. It's like a PFM crown or a CMC crown or a bonded crown. It all means the same thing. We just like to make it confusing. RCP to ICP, that is, we're going to go into this. Okay, RCP is the first contact that you will have if your condyles, okay, so condyles are this bone here, okay, if they're fully pushed back, okay, and fully seated into this. So this is like a ball and socket joint, okay? So if I'm to do it like this, okay, so I've got a socket here, this is the ball, so it needs to be fully seated, okay? That's what we're trying to do with RCP, okay? It needs to be fully seated. In the normal, when we're normally eating, it's not fully seated, okay? So we need to push it back. So then it starts working like a circular motion, and we'll go over this later on, okay, what I mean by this RCP contact, and I'll draw a little circle and a diagram to explain what this means. But when we're basically, when we push our jaw back, okay, and bone's hitting bone here, okay, it's fully seated, our jaw works like a circle. Otherwise, our mouth does not work in a circular motion. When we push it back there, ask the patient to bite back, we saw that the upper right 6 hits the lower right 5. And that's important because we'll teach you in a minute why. There's a vertical slide and a horizontal slide. What does that mean? Okay, vertical slide means if there is, if when the teeth touch together, so when the upper right 6 and upper right 5 touch, do they go up and down vertically against each other? And horizontal slide is if the upper right 6 and 5 touch together, do they go side by side? That's a horizontal slide, okay? So that was about 2 millimeters. There's compensated localized tooth wear. What does this mean? Okay, so that means that the teeth are grinding down. So as time goes along, if you start grinding your teeth, okay, teeth become shorter, but that doesn't mean you end up with an open bite, okay? If you have a look at his teeth, okay, you'll see that the gum levels are going up, so the bone will start pushing the teeth up, okay, or start pushing the teeth down, and that is called compensation, okay? And then we're going to go on to ACE classification. Jin will explain what the ACE classification is and why this is a grade 4.
Fantastic. So some of you 4th and 5th years, or especially your 5th years, should sort of revision for you guys and should be knowing sort of roughly what's going on. A lot of you 2nd and 3rd year guys, this will be sort of new topics, new terminology, which we're introducing today. So don't worry too much if you're confused about all this stuff. This is quite in-depth occlusal examination. I want to give you guys a sort of an insight into what we do for our larger cases as well. And again, as I go through case classification, we'll go through that.
You know what? I'd just like to point out to everyone there, if you're in your 2nd, 3rd, or even 4th year, even in your 5th year, this is a lot to take on. It's just to show all the stages and what each thing means. It's just an introduction. It's not there. So, oh my God, I didn't know this. I didn't know this stuff till about 5, 6 years out of dental school. That's when I learned this stuff. So, because I mean, I wasn't the best of students either, but that's a separate topic altogether.
Okay, so then what we've gone on to do is we've done a aesthetic analysis. Now, what we're doing in the aesthetic analysis is firstly checking the smile line. So you can see he's got quite a flat smile line going quite across, very flat smile line. His lower lip line, again, very similar, average and flat. His incisal edge position is short of the lower lip. His center lines, you can see, give me 1 second to stop sharing. We're back on again, cool. So his center lines, you can see, are coincident over here, which is good. Occlusal plane is on quite an exaggerated curve of SPE, which can be seen. Again, his tooth dimensions, if we look at the centrals, they're very short and wide. Poor loss of contour, very poor color. Angulation is fairly good. So when we look at angulation, we're looking at the angulation of the teeth, and I would say it's fairly good following the principles of smile design. Okay, and gingival levels, again, we're checking the levels of gingiva. They are all coincident as well. So overall, smile analysis wise, mainly it was a smile line which was quite flat. along with the shape of the teeth, which was quite wide as well. We did a full mouth periapicals. So in our practice back then, we didn't have an OPG machine or an ECT scanner, so we did full mouth periapicals, assessing the bone levels for pathology, caries, and what we can see is looking at each tooth, all the teeth, and we do a tooth by tooth prognosis of each tooth. And generally all teeth have a guarded or good prognosis, which is good. And another thing I'm in quite a good habit of doing is assessing clinically, plus on the radiographs, the presence, how much enamel there is. Because when we're looking at bonding, we need enamel. Bonding to dentine is not as predictable. So again, looking on the x-rays, checking clinically, I always check how much enamel is present. And again, we can see all teeth have enamel present for bonding. So again, when I'm looking at my options, I can look for a more bonded option as opposed to more conventional prepping options as well.
Yeah, and the key thing for bonding, as Jen has said, is the amount of enamel that you have. If you don't have some rare cases we see where the tooth surface loss is such where they've lost a lot of enamel, that makes bonding very difficult. Okay, so they're not ideal cases just for composite. We might need to think of other things, but enamel is key for bonding, and dentine is key for keeping the tooth strong.
Yeah. So again, a lot of studies have shown, I mean, the failure of veneers, majority of veneers fail when there is lack of enamel. So it's very important when you're looking at any bonding, whether it's composite bonding or you want to bond veneers, you need enamel present. Next, we went and to do special investigations. So as we said, we've done radiographs, long cone periapicals of all the teeth. We did some study models with a face bow and something called a tooth apart record. We did photographs, we did vitality testing of all the teeth, checking if the nerves are vital. And we also did tender tooth percussion. So we're tapping teeth to checking the tenderness of the. Go, Ali, go for it.
I mean, I think, you know what, as I call it, percussion testing. Okay, I think that's our favorite thing. We love getting a mirror and just smacking you on all the teeth. You know, one is like you know, we enjoy it. But yeah, it shows a lot. It's so useful, and I think as with time, you actually start enjoying it more, knocking on teeth. So yeah, definitely.
So what happened? We went and got some diagnosis, okay? So the diagnosis we got on this case, we had multifactorial tooth surface loss. So any case you do, whether it's a chipped filling, lost crown, we need a diagnosis. And in this case, multifactorial tooth surface loss, so there's a combination of erosion, attrition, abrasion, and abfraction. We also had edentulous spaces, upper and lower arches. So missing teeth, gaps, upper and lower arches. And we had our aesthetic diagnosis, which was quite a flat smile line, tooth were quite wide and short, loss of contour and loss of color. So at this stage, we had to go through a few options of what we could do with Steve. And you can see in the background here, Steve's teeth on presentation, we had a few options that we could do. So plan-wise, what options did we have? Either a direct composite approach, a indirect and direct technique, something called sandwich technique, or go old school, conventional crown, start prepping. And if you ask me when I first qualified 10, 11 years ago, I probably would have said either conventional crowns would have been the modality as well. Ali, what would you agree with that?
Yeah, I mean, absolutely. So when I had graduated as well, the go-to thing for such a case was prep it up. Let's start prepping and, you know, prep all the teeth. Maybe we might not have prepped lows. Maybe we would have prepped even the lows as well. Hey, so, but yeah, that would have been definitely have been the preferred option at that time.
Direct composite, indirect sandwich technique, conventional crowns. So not a lot of you would have heard about a sandwich technique. And this is what we're going to discuss, this sandwich technique. I know the lecture title of this was Minimally Invasive Aesthetic Dentistry, the Fast Approach. And a lot of you guys are probably tuned in thinking, these guys are going to show me how to bang out a composite in 20 minutes or do bonding in half an hour. There's nothing fast about this approach.
There's nothing fast about the fast approach.
So we went for the sandwich technique. And why did we go for this? So Professor Velati and Professor Belsar from the University of Geneva, they came up with this ACE classification, anterior classification for erosive wear, okay? And this is very much management orientated. So the ACE classification is management orientated. It only deals with anterior teeth and is based on palatal enamel, palatal dentine, incisal edge length, and facial enamel and vitality. So I'm going to introduce to you this ACE classification because when we learned it, I thought it was a fantastic way of assessing tooth surface loss and, more importantly, planning these cases as well.
Because you know what it is, the most difficult thing is what treatment option do we go for? Treatment planning, I think, takes years to learn, and there's so many options. It's exactly like uni. You know, I remember in dental school, every consultant you go to has a different treatment plan, has a different preference, okay? So, and what ACE did and what Prof. Velati did is they just gave you the answer. If they're a code 1, this is the answer. If they're a code 2, this is the answer. And that's what I like about it.
So here we've got ACE classification 1. In ACE classification 1, you've only got thinning of palatal enamel. And the treatment for this is no restorative treatment needed. Okay, so ACE classification 1, slight thinning of palatal enamel, no restorative treatment needed. In ACE classification 2, you've got dentine exposure on the palatal aspect. In the contact areas, no damage to the incisal edge. For this option, what they recommend is direct or indirect palatal composites. So firstly, a lot of you guys are thinking, why are these guys chatting about palatal aspect? You know, we thought labial or the buccal was the most important. For us guys, palatal is the most important. Why is that, Ali?
Absolutely. This is a common mistake. Okay, so a normal question we ask, and guys, if we see you next year and we ask you, for dentists, the palatal surface is the most important. For patients, the buccal surface is the most important. Patients are interested in the aesthetics. We are interested in how long it's going to last our work, okay? And how does it function? So it's the function part. The occlusion part is determined by the palatal aspect. And that's why the palatal aspect is the most important for us to learn. I mean, I know I've met some young dentists, they didn't know that their composites were chipping and their bonding cases were failing because what they would do is they'll get the composite and wrap it around the incisal edge. As soon as you do that, you're changing or affecting their bite. So yeah, palatal aspect is important for us, buccal aspect for the patients.
And the most important thing about dentistry, what we do is predictability. And this is something you heard your tutors say, your professors, you want predictability. What that means is you want to know what will work in your hands and how long it will last in your hands and in that patient's mouth. And only that way can you charge what you want to charge that patient. Absolutely. You don't want to charge a patient a couple of £1,000 and within 3 or 4 months, everything's chipping away and failing. Hence, when you're planning these cases, it's the occlusion, hence the palatal aspects, the most important, as highlighted by Professor Velati and Belsar as well. So ACE classification 3, this we've got dentine exposure on the palatal aspect, and you've got damage to the incisal edge, but less than 2 millimeters. So dentine exposure on the palatal aspect, dentine to the incisal damage to incisal edges, less than 2 millimeters. What they recommend is a palatal veneer. Okay, palatal veneer. Moving on to ACE classification 4. Here we've got extended dentine exposure on the palatal aspect, loss of tooth length greater than 2 millimeters, but you've got preserved facial enamel. And this is exactly how Steve presented to us. In this situation, what they're recommending is a sandwich approach. So in the sandwich approach, you're going to use one material labially and another material palatally. So using 2 materials. The way they describe it is you've already got a patient who's lost a lot of tooth tissue already. Why are you going to drill even more tooth tissue away to smack on some big crowns. So again, in this situation, you're putting on a palatal material and another material labially, called the sandwich approach. Again, ACE classification 5, this is when we've got extended dentine exposure on the palatal aspect, loss of tooth length greater than 2 millimeters, and loss of facial enamel. Again, in this situation, we've lost a lot of tooth tissue. They say you could attempt the sandwich approach, but it's very much experimental.
In this
And
case,
then you've got,
I think it's just calling for, I think class 5 and above, in my opinion, is calling for a crown.
perfect. And then you've got ACE classification 6, advanced loss of tooth structure leading to pulp necrosis. Again, they say sandwich approach is highly experimental, but again, as Ali said, I would go for probably old school conventional crowns, or possibly RCT, post-core, and crown. Would you agree, Ali?
Absolutely, yeah. I mean, as soon as it's going into the pulp and leading into pulp necrosis, on a tooth wear case as well, depending on how much load we're putting on, I'll be going for a post-core approach or a conventional crown approach here.
So that is the ACE classification. What I'll do, I'll send Niji the journal as well, so you guys can distribute and have a read through it. And again, a really good way of assessing anterior erosive wear and planning these cases as well. So once we had decided we're going to go for a sandwich approach, what we did was we took impressions of the patient. We took a Facebook record. Now, I'm going to ask you a question, Ali. Can we got the chat box up there? Does anyone know what a Facebook record is? Can anyone write down in the chat box what a Facebook record is? Why do we do it? And we have got some prizes to give away today in our webinar.
So what's Facebook, guys?
What a Facebook is?
Either unmute yourself or you can come on the chat and write it down. Okay, so we've got Nikki Chung, records centric relation. Mohammed Adam relates maxilla position to condyle. So Mohammed Adam was the first one to answer that. Okay, relation of the maxilla to condyle shows the relationship between the maxillary plane and condyle. Excellent. That's absolutely it, the correct answer. Mohammed, what year are you in? You're going to come out and say your second year? Oh, fifth year. All right, man. That's why he knew the answer. Fifth year. So yeah, absolutely. All the articulator does, all the Facebook does is it gives us a record or the position of our top jaw compared to our condyle here. Okay, so everyone's jaw is different. Okay, so my jaw might be bent, it might stick out more, it might be lower. Jin's is going to be different. Okay, so it completely depends, and that's all the Facebook does. It provides the record of our maxilla to the condyle.
Perfect. So Mohammed Adam,
we can use it to put it on an articulator. That's it. Perfect.
So Mohammed Adam, I'm assuming you've already done your DFT stuff or doing the process. So what we'll do to you, I'll give you a free place for one of our Smile Design and Photography course. So drop me a message afterwards and I'll get you into one of our courses for free as well next year. So drop us a message. Well done. So as Ali said, the Facebook is used to get the patient or get Steve onto an articulator. So an articulator is having a copy of Steve's jaws outside his mouth. So we can assess and check what is going on with his teeth in different positions. So in this articulator, you can see this is Steve biting down comfortably in his ICP, intercuspal position or maximum intercuspation. So him comfortably biting down, just putting his teeth together.
Exactly. That's what ICP is. It's just when you clench your teeth together or put your teeth together, that's what ICP is. And this is his normal bite, what I call the normal bite. That's ICP, and you can see it there.
Then what we did is we got the patient and we got records to check where his first point of contact was in that retruded position. So what Ali was saying before, your retruded arc of closure, your RCP position, and this was Steve in his RCP position. So what we can see he's touching on the lower right 5 with the upper right 6. Exactly what I documented earlier on. So when we put him in the retruded position, that first 20 millimeters of pure rotational movement, he hits that tooth. And what's happening with Steve is first 20 millimeters, he hits the lower 5 on the upper 6, then he slides into the image on the left. Yeah. So Ali, do you want to go through it one more time?
Absolutely. So the whole idea behind centric relation or retruded contact position or retruded arc of closure or retruded arc position, okay, is that the jaw joint here, okay, is fully seated into your socket here. Okay, so like I said, it's like a ball and socket. Normally our jaw joint's about here. Okay, so if this is our condyle, okay, that's our jaw joint. So if it represents it. If I'm sitting there, standing here like this, it's normally about here. Okay, so when we're normally eating, it's working around, moving around, left, right, forward. That's how it's working. It's not fully seated. But when we're working to change someone's spine, okay, or when we might be working on all the teeth, we need a reproducible position. Okay, we need a reproducible position, and that's why we must send it home. Okay, and this is the analogy I'm going to use later, okay, for me to describe this process. Okay, so it needs to be fully seated, it needs to be fully home. Soon as it's fully seated in this socket, okay, then it only works like a circle. Okay, and it's a circular movement, exactly like a compass. Okay, for the first 2 centimeters or 20 millimeters of opening. After that, then after 20 millimeters, it starts dropping down as well again. Okay, so all we mean by RCP, okay, all we mean by RAP or centric relation, it's not a tooth position. Okay, it's a position of the bones. It's the position of your condyle, which is this bone here, and your socket here, which is called the glenoid fossa. To make it more complicated, the socket ball, okay, when it's fully seated, that's what we mean by RCP or centric relation. Okay, and that's key because if we, for example, completely, none of these restorations work out, or we start preparing all the teeth, okay, or we don't know we start changing the shape of all the teeth, we need to go back to a position which we can reproduce, something not dependent on teeth, something dependent on bones, skeletal bones. They're not going to change shape or size, okay, exactly like that. They're not going to grow, they don't get worn down. So that's why we need to make sure this is pushed back. And the way we've got several methods of pushing stuff back, okay? We've got several methods of pushing the jaw back. We've got a Lucia jig, which is just a plastic thing which you can push your jaw back with. We've got a leaf gauge. All these things are techniques where you just push your jaw back. The easiest way is getting someone's jaw and shoving it back, okay, which is called manual manipulation. Okay, you can do it manually and push their jaw back. That's what RCP is, and it's key here because we can see that RCP, the first contact point is the upper right 6 to the lower right 5. Why is this important? This is important because in an ideal occlusion, okay, RCP equals ICP, okay, and you give them canine guidance and you give them even contacts on protrusion, okay, and when they're grinding side to side, no back teeth are hitting. When they're pushing their jaw forward, no back teeth are hitting. This is an ideal occlusion. If you're going to give someone a new bite, you might as well give it the perfect home, right? So if you're going to redraw, if you're going to be an architect for a new home, go for ideal characteristics, and these are ideal characteristics. This occlusal scheme or this design is called mutually protected occlusion. Okay, so it's called mutually protected occlusion, and that's one of the things. RCP equals ICP. So we now know that is the point that we need to build up all our teeth to.
And that is exactly what we did. The technician then waxed up the end result teeth based on that RCP position. So this is Steve's now, this is going to be the new end position. This is called a wax up, a diagnostic wax up. Okay. And the wax up Again, you can see this is Steve's study models pre-op. And the technician has now waxed it up on the articulator for the end result. And we're looking at the labial surfaces, which the patient will care about. But the most important thing for me are the palatal surfaces. And again, this is what I want to drill home to all of you guys is how important palatal aspect is. We're not just slapping on a bit of composite on the front and sending Steve home. We want to plan it long-term. We're planning long-term. We want our dentistry to last. And the most important surfaces are the palatal. So this was Steve before. And again, this is Steve's wax-ups done by the technician. And you can see the amount of palatal anatomy we put in, amount of palatal surface we put in, and the ramp. So at least Steve has got enough material to work with. You know it's going to function and last well as well. So then we went on to do a trial smile, something we call a mock-up, where we try his diagnostic wax up in the mouth. So we're trying everything out. There's no surprises. There's no just trying everything, you know, ta-da, this is what we've done. We are actually trialing out the smile. So this was Steve before, and we have now copied over the wax up into the mouth to check it. And this is called the trial smile. And here you go, Steve. His smile's even got bigger now. Okay? So this is called a trial smile. So my next question for the next prize. Why do we do a trial smile? Let's get you guys. Let's see what we got.
Yeah, make sure the patient is happy, to test the occlusion, to assess function, aesthetics, occlusion, to identify any potential problems in case we want to change the wax up, to make sure the bite is correct so that no restorations chip. Make sure patient likes it. If they want to make any changes before prepping, it's the reversible stage. Perfect answer. Perfect answer there.
So until now, we have done nothing to Steve's teeth. We've done nothing. Fully reversible at this stage even. He might even look at it and not like the look of the teeth. And we don't want to be in a situation where we do something, you know, which is irreversible and he doesn't like it. Because undoing it is impossible. We can't give it back. We can't drill off something.
And that's a common problem that we see, okay? So what a lot of our colleagues will do is they'll basically work to the best of their abilities, finish the smile makeover, and they're like, voila, and the patient's like, I don't like it. They're too square, they're too round, they're too long, they stick out too much, all types of things, okay? So that's why we always work backwards. We know the final result before we start. And now most patients, okay, 9 out of 10 would be happy, okay? Now, no, actually, let me give you the percentages, okay? 2 out of 10 would be happy with the first attempt. Jin, would you agree with that?
Totally agree.
Another 7 out of 10 would require another 2-3 adjustments. So here you can see Stephen, he wants more, and Jin's gonna go over it. He didn't like it, it's rounded, he wants some more square, etc. And 1 out of 10, ladies and gentlemen, 10%, will not be happy. They won't like the thing, and it's best to say goodbye at that time when you haven't done anything. Otherwise, the worst thing you can do is you can do a Turkish delight, which is you do the whole smile makeover like they do in Turkey in 4 or 5 days or 3 days, okay? And you give the patient a smile, and whether they like it or not, they're stuck with it, okay? And you don't want to do that. You want to make sure that the patient's going to be happy with it. We can make any adjustments, and if they're not going to be happy with it, we don't go ahead with it. And we can also check our occlusion as well.
So exactly what you guys said, why do we do a trial smile? And this is where we're going to introduce you to the fast approach. This is what we are assessing. We are assessing the function. We are assessing aesthetics. We are assessing the speech, and we're trialing it out. So we're trial running it, seeing how it is, and it may not work, patient may not like it, loads of different things. We do not want to do things that are irreversible, and we want to make sure once we're happy, we copy and paste it.
Absolutely.
And work with our copy and paste technique as well. So when we are looking at function, what are we looking at? And Ali will go through this with you.
So guys, again, we're coming back to occlusion. Now, the reason we're going to repeat this, it's intentional, by the way, okay? Repetition equates to learning. Okay, so as passionate teachers, not only have we studied a lot of clinical dentistry, but we've actually studied a lot of teaching methods and a lot of learning methods, and then recently how to communicate and how our brain processes information and understands information as well. Okay, the key thing is repetition equates to learning, and we're going to keep on repeating this message. Now, why is occlusion important? Okay, so this was my finals question. Okay, why is, Mr. Chauhan, why is occlusion important? Okay, and the answer is because it allows us to load the teeth, or allows us to control the load on the teeth. Okay, so occlusion is important because I can change the shape or the position of the tooth, and I can understand how much load a tooth is carrying. That's what occlusion is. Okay, so what do we want in an ideal occlusion? Okay, the ideal occlusion, like I said, is called a mutually protected occlusion. Okay, and the characteristics of it are, it's got multiple simultaneous contacts of posterior teeth when you're biting down. Okay, you're not just biting down on one tooth at the back. Okay, you've got multiple simultaneous teeth. Okay, the arc-centric relation and maximum intercuspation. See, even we've done it. Okay, so maximum intercuspation position, centric relation, RCP, RAP, all the same thing. Maximum intercuspation position, or ICP, the same thing. Okay, so they need to be coincident. Okay, naturally, only 10% of the population is this coincident. 90% of it is not coincident. Okay, in dynamic occlusion means when you're chewing, okay, when your jaw is moving around, that's what dynamic occlusion is. Static occlusion is when your teeth are just put together. In dynamic occlusion, we want the back teeth not to be touching when we push our teeth forward. That's what posterior disclusion means in protrusive guidance. So like I said, protrusive guidance is pushing your teeth forward. Okay, put them together, push them forward. Back teeth should not be touching. Canine guidance in lateral excursions. Okay, that means when you grind side, this is to the left, this is to the right. Okay, none of the back teeth or premolars are touching. Only the lower canine and upper canine are touching. That's ideal. And the reason it's ideal, okay, why is canine guidance? We keep on banging on about canine guidance, okay? Canine guidance is ideal. Canine guidance is important. Why is canine guidance important? Because they're long, strong teeth. They can carry weight, okay? So they've got a very long root. They've got a very strong root. Those of you who've done a bit of oral surgery and have taken a canine out yet know it's a difficult tooth to take out, okay? All right, it's a big tooth, long root. It can take the load. All right. The second thing with the canine is it's in the corner. So where the jaw starts turning, anterior teeth, back teeth, is in the corner. So you want the forces as far forward as possible. Okay. All right. So that's what you want. And you don't want, you want absence of non-working side contacts. Now, what does that mean? Okay. Working side is, so if you put your teeth together, I want you to do this. Okay. So I'm going to ask you, put your teeth together. That's your ICP. Grind to the left. So notice what teeth are touching when you're grinding to the left. If only your canines are touching, your canine guidance. If your premolars are touching or more teeth are touching, your group function. This is your working side. Okay, so when you're grinding to the left, push your jaw to the left, your left is your working side. Your right is your non-working side. And when you're pushing to the left, you should have no contact in the right side. Okay. Otherwise, that's destructive. And I'm going to give you I'm going to break this down in an analogy so you can understand this, okay? So canines, okay? Canines are strong, okay? They're in the corner. They can carry a lot of weight, ideal for a relationship, right? Everyone wants to be like, you know, look at Jin, he's strong, built, you know, you want a funny looking, you know, funny guy, strong guy, goes to the gym, all done, okay? That's canine for you, okay? Now you want an opposing canine for that as well. okay, someone who matches Dr. Jin as well and can carry the load, that's ideal. Now, if you are group function, okay, that's when other people start interfering in the relationship. So there's an ideal relationship is 2 people or 2 teeth. As soon as you start getting interferences of others, this becomes a group function thing, it's more destructive. So that's why group function is more destructive, because there's more teeth involved. And as soon as you've got non-working side interferences, that means now it's not even like family and friends, it's other people getting involved, okay, non-working side interference from work or whatever, or dental school or other places, that's when it becomes even more destructive, okay? You've got more interferences, more people getting involved, and that's not ideal. So I remembered it like this. This is how my tutor explained it, okay? So it's just an analogy. It's like a relationship, okay? You want 2 strong teeth together, ideal. 2 people in a relationship, okay? You get 3, more destructive. 4, more destructive. 5, even more destructive. And it's the same with teeth as well, especially if you have non-working side interference. Jin, would you agree with that?
Totally agreed. A very good analogy for remembering it as well.
Yeah, absolutely.
Love it. Okay, so look, guys, that is what we're checking for function, okay? And Ali summarized it well. Again, a lot of you guys, 2nd, 3rd years, we're going to introduce you to a lot of terminology today. 5th years, this is something you probably would know again, so it's revision. So fast approach, function. Next thing we're assessing is aesthetics. Now, what are we assessing with this? We are checking facial perspective. We are assessing the dental facial perspective, okay? We are assessing gingival perspective, and we are assessing the dental perspective in terms of the teeth. So we're checking smile line, lip line, shape of the teeth, gingival lens. We're checking how wide they are, gingival contours, loads of stuff we're assessing, which are the fundamentals of smile design as well.
Jin, just to tell you, it's 8:25.
Perfect. Yeah, got it. Don't worry, bro. We got it.
All right, cool.
Passionate educators. We're going to finish 11 tonight, yeah?
Yeah, the way we're going, I think we're going to finish at 11 if we do the whole lecture.
So that's aesthetics. Then we assess speech, okay? Now, when we're assessing speech, there are certain sounds made by certain parts of the mouth as well. So palatal lingual sounds are produced by tongue, hard palate, and soft palate. You've got linguodental sounds produced by the teeth and tongue. You got labiodental sounds produced by lips and teeth. And these are really important. These are F and V sounds. And then you got bilabial sounds produced by the lips. So when we are assessing speech, we're assessing particular things. So just to give you a synopsis, if you got a patient in a trial smile, and this sort of touches base with dentures as well. Some of you guys might be on the denture clinics recently. If the whistling sound is produced when with the sound S, what's happening is the anterior part of the tongue is obstructed by the upper premolars, making a groove too large for the escape of air. When you got lisping sounds with S, again, the area is too small, and it's quite common with dentures. Airspace is too small. So what you may need to do with your dentures is your palate or your palatal coverage is too thick. Again, with th and ter sounds, which are undistinguished, there is inadequate interocclusal space, or the anterior teeth are far too lingual. The lower teeth are far too lingual and must be moved labially. And the normal F and V sounds, the upper anterior teeth contact the lower lip at its highest point. If these sounds, you can't distinguish between them, the upper incisors must be moved either vertically, okay? So again, these are things we're assessing with speech, and there's particular things we do with our patients at this appointment. And again, the final bit, we are trialing it out. And in this bit, what I mean by this is you want to make sure the patient's happy. You want to make sure you are happy. Make sure the technician is happy. But most importantly, make sure the patient's partner, husband, wife, okay, if they've got girlfriend, boyfriend, whoever it is, bring them into the appointment. Super important. They need to be involved as well. We've had cases, patients have done work, they've gone home, and they've gone, my wife hated it, or my husband hated it.
I'm almost insistent on this. I would ask them to bring their partner in. Okay, so I would ask them to bring their partner in, and unless they're insistent on saying no, 90% of them will and bring them in. I just want that opinion, because this comes with experience, and you realize they go home and they're happy, but the partner isn't, and that can cause, you know, you might be redoing the work because of the partner's dissatisfaction. So definitely insist on them coming in and getting a second opinion.
Fantastic. So once we are happy with the mock-up, the diagnostic wax up, and we're happy with our fast approach, then we can get our restorations made. So in Steve's case, what we've decided to do is gone for a sandwich approach. We have decided to go for palatal veneers, indirect, made from the lab. Reason being, I want to make sure these are precise. These are tested in the lab. I don't want any guesswork. So we had indirect palatal veneers made in the lab.
And it makes your life easy as well, right, Jin? Because you're just cementing stuff on. The palatal part is the most difficult part to build up. And you've just made your life easier because you've just taken an impression and got this made, right? That's it.
So this is what we got made. We've got gold palatal veneers on the canines, the strong teeth Ali was talking about, and we've got composite indirect palatal veneers 2:2. Okay, so gold on the canines, palatal veneers, and we've got composite 2:2, again, all made in the lab. Now, Ali, why would we have gone for gold on the canines?
I think we should ask the audience, why do they think? Any guesses as to why we've chosen gold for the canines? Pop it in the chat. Why gold in the canines? Thinner, stronger in thin sections. Yeah.
Very good, fantastic. Less likely to wear than composite. Perfect.
And thinner, stronger in thin sections as well. So definitely you can have, you know, you can get away with less in gold as well. And ladies and gentlemen, of course, the other reason is, remember, okay, that canines are going to be taking not just the load of the bite. Okay, so in ICP, they're also providing lateral excursions as well. So when you're grinding side to side, all that load, majority of the load is going to be going on the canine. So we really want something really strong and hard, robust on the canines.
Perfect. So all of you guys said exactly it. Sonna said canines bear the most load. Sam Matthews said better mechanical properties. Fantastic. Nikki Jong, again, gold's wear is similar to enamel. And Megan, less likely to wear than composites. Fantastic. And these are our restorations, okay, made from the lab. So now we are ready for the next stage. So we are going indirect palatal veneers, and labially, we're going for direct composite bonding. So the first thing we do is we cemented on our palatal veneers. We've cemented the gold on, and we've cemented on the composite palatal veneers. And here you can see how it looks with it cemented on. We've cemented the gold ones on first.
So we've got a question. Did you prep the palatal surface for those restorations? Daniel, no, we didn't prep the surfaces at all. This is completely adhesive. Even a second-year student can do this. All you need to do is take an impression. That's it.
It's the planning that is the hard part, but this is proper, minimally invasive. Absolutely no damage is done to the teeth at all. Yeah. And then we cemented it on the labial, the palatal 2:2. Next, what we did is we went on to do the labial direct composite bonding. So the first thing I did is I etched the tooth. So question, how long are we etching for? In the chat box again, guys, how long are we etching for? 20 seconds. Oh,
Niji, as per manufacturer's instructions. Very clever. Good.
Emma Gray, good. According to manufacturer's guidelines. Ali, how long are we etching for?
So, ladies and gents, if we're using 37% phosphoric acid, first of all, you should use the manufacturer's guidelines, because whilst it's 37% phosphoric acid, all the remaining 63% is different stuff depending on which brand you're using. So manufacturer's guidelines is number one, okay? Number two is for enamel, minimum 30 seconds. You should do selective etching. It's not a squirt all over the tooth job, okay? Put enamel first, 30 seconds, Dentine is 15 to 30 seconds, or if it's a tooth wear case, like Stephen here, for the lower incisors, okay, where you've got a sclerotic dentine from tooth wear, it's really blocked up, it's 90 seconds. Okay, so it completely depends, and this is the key. Remember, if it's an adhesive case, we haven't prepped anything, we're completely relying on the bond. So the bond needs to be 100% true. If you're gluing something on, the glue needs to be 100%. Can't skip any steps there. So that's why manufacturer's guidelines is the one about this. Do you have papers to read about this? I'm sure Dr. Jin will forward you the papers about selective etching.
So again, now we're going to go through some of the basic stuff and stuff for you second and third years about to start clinics, and go through some basic stuff regarding clinical tips as well. Next question. So I put the etch on and then I washed it. Washed the etch off. How long are we washing the etch off for? Very common thing we all get asked every time.
How long are we, guys, pop your answers. How long are we washing the etch off for? Until it's completely gone, as long as the etch was, oh, very clever. Yeah, Radhika's right. Okay, so as long as the etch was on there for is the correct answer. Okay.
Fantastic. And again, very common. You know, people put etch on for 30 seconds, one squirt, done. Make sure you're washing the etch out, as Radhika Shah said, as long as the etch was on there for.
And next, the reason is you really want to wash out all the etch. Okay, because if there's any etch still stuck in there, you're going to get sensitivity and you are going to get interference with the bond.
And then we went on to the bonding stage. So, question about bonding. Here we're using iBond, which is a universal bond. Even with this, I still do etching. What is our gold standard bonding protocol? Let's ask you guys. Bonding protocol, gold standard. Right in the chat box.
Well, I think what Jin means by that is don't let it pull, small layer, okay? I think what he means by that, is it etch prime bond? Is it etch and bond? Or is it like universal bond here? You just pop it on all in one and just do that. What's the best of the best, the gold standard? Absolutely. Nikki's right. Etch prime bond, the 3-stage is the correct answer. Nikki, what year are you in?
If she says second year, there's something dodgy going on there.
Final year. Okay, all right. That makes sense. So it's just the reason I'm asking is that our second year and third year students might be thinking, how come Nikki knows everything? And it's just to, you know, make them feel normal is the word, okay, that you're in final year. Good, good. She's revising, that's why.
So any of you second and third just want any notes, you know who to approach. Nikki,
yeah.
will come there, all of you guys. All right, so look, we're using a, as Nikki said, etch prime bond, which is a 4th generation, tend to be the gold standard. We still tend to use either iBond or OptiBond Solo, which is a 5th generation. What that means is you got separate etch, and then you got prime and bond together. Okay. Using a micro brush, you apply it, and this is very, very important. We do not want to put loads and loads of bond, okay? So again, this shows you don't want loads of bond. You want to apply a little layer. You don't want it to pool up and like soak the whole tooth. So make sure you've only got a little amount that will cover the surface, okay? And then the next thing you do is light cure. So my favorite question, how long are you light curing your bond for? In the chat
box. How long
box.
do you light cure for, guys? How long do you light cure bond for?
And let's get the second and third, if any of you guys are on here, let's get you answering as well. How long are you curing it for? How long do you think? Anyone want to put it in the chat box? How long are we curing for? Is it 5 seconds? 20 seconds? All right. So again, look, light curing. Firstly, as Niji said before, follow the manufacturer's guidelines. With all the bonds we use, it will say exactly how long you want to cure it for. But as a matter of rule, what I do is minimum 40 seconds, whichever bond I'm using. So at least I know definitely it's been cured. Do you agree?
I agree. Yeah, I mean, this is a common thing. I mean, the best answers we normally get is till the machine beeps or till the nurse feels like it. So it's minimum is 40 seconds, but you must read the manufacturer's guidelines. Okay, very rarely are they, less. Nikki's asking, you can't overcure. You cannot overcure bond. No.
Yeah.
Yeah.
Brilliant. And look, I use Venus Pearl for my composite. And again, it says it on there, 40 seconds. Even says how long you should cure it for. Venus Pearl is a nano hybrid composite, really good polishability, and that's what we use in practice. So with our composites, our technique, what we do is, again, we use separate instruments, flat plastic, you get the composite, we use brushes as well. Again, if you're going to use these brushes, make sure you are disposing them afterwards. Obviously, Corona times, make sure infection control. And one of my favorite instruments to use in practice, which Ali introduced me to, is the Optrasculpt. So it's a little instrument. One end is like a flat plastic. Other end is like a little pad that you can really apply the composite with, and it helps with the bonding as well.
Honestly, nothing sticks. It's like a pad. I suppose is the best way to describe it. It's like the perfect texture pad. Okay, so those of you who use foundation, you know anything. It gives you the perfect texture and the perfect touch with it. That's exactly what it does. It doesn't smudge, it doesn't stick, and it's amazing. So Optrasculpt brush, I don't think you'll be using it in uni. It's mainly used for buccal composites. So if you're doing a lot of this work, because it is quite expensive, it's a must-have instrument in the future, definitely.
And again, you use these instruments. So going from here with Steve, we're a direct composite onto here. So we've applied all the composite to this. The most important part of the composite bonding now, we're looking labial surface, is our polishing. And when we're looking at polishing, it probably takes me twice as long to polish it as it does to apply the composite on the tooth. So I'm going to go through the principles of polishing and how we do it. The first thing we do is our primary anatomy. What I'm talking about is the shape of the tooth. Get the general shape of the tooth, get the general outline, and that's our primary anatomy. And the instrument I use to get the primary anatomy is the burrs. So it's normally a diamond, long diamond burr I use to get the primary anatomy. Normally, when I'm doing the bonding, it'll be very little adjustments needed for the primary anatomy, but this is the burr I would recommend. The second thing we do then is go into secondary anatomy. And secondary anatomy, what we're looking at is probably the most important thing to me, our line angles. So line angles, as you can see clearly, and I've highlighted them here, is where the tooth changes shape and where the light hits it, and you can see the reflections. It's when the tooth bends around and you can see the reflections. Depending where you put your line angles, teeth can look shorter, teeth can look narrower, wider. You can do a lot of things playing around with line angles. And I would say this is probably the most important thing when it comes to polishing your anterior composites. Ali, do you agree?
Absolutely. I mean, so if we're to remember, primary anatomy is about the size of the tooth, overall shape of the tooth. Secondary anatomy is to start giving it, texture, not texture, but the actual using the light to its advantages. It's exactly like a haircut. You go to the hairdressers or the barber. First, you need to choose length. Are you having short or long? Okay, that's primary anatomy. Secondary is, are you going for curls, little flicks, etc. Okay, and then tertiary anatomy is the texture, when they start like flicking little bits off, etc. So that's how it works with the tooth as well. Okay, so primary is the shape. Secondary is how you can manipulate the light. So if we are looking at this, so what we mean by line angles is where the tooth curves. That's what a line angle is, okay? So the tooth comes in, into, mesial wall comes in, and how it curves. Some teeth have a very sharp curve. Some teeth have a very gradual curve. Some teeth are curving in like that. someone like that. That's what we mean by secondary anatomy, and it's the most useful part to understand.
Instrument I love to use for this is our soft flex discs. So I love to use a soft flex disc. It really helps getting the line angle. So you might use different types. But again, really nice instrument to use. Then you've got your tertiary anatomy. And again, this is if you want to put it in. In this case, I didn't do it. These are our lines that go across the teeth. Anyone know what these lines are called? Put it in the chat box.
What are these transitional lines called? Ah, perfect. Pericymata, absolutely.
Well done. And again, this depends on your patient, and depending on what you want to do with this, you can make it really natural, but the trend at the moment is patients do not want that. They want that blocky, one shade, color look as well. Next thing we go for then is our polishing. And again, to do the tertiary anatomy, what I tend to use is your diamond burr. You roll the diamond burr across on a very small revs, and that will cause the little lines pericymata across the tooth. Then you're ready to polish up. And this is where I go through my sequencing of soft flex discs, making your way from the most coarse one to the most fine one. So the ones I use are all different colors. I make my way through all the soft flex discs, all the different colors. Then I would go into diamond polishing paste. Then using the rubber wheel at the end to get the final polish. And then what we're checking is interproximally using the interdental polishing strips to get the right finish. And again, making sure Steve can still floss between the teeth. So we've gone from here to here. And we've even given him a bigger smile as well. He's actually trying to smile now.
And that's I think that's a separate topic that we obviously are very passionate about. We won't go into at the moment. Jin's already smiling before I get accused of making it too airy-fairy. The nicer the patient smile, the more they will smile. The more they will smile, ladies and gents, okay, the more happy hormones they produce. So I'm talking about serotonin, dopamine, okay, and it makes the patient more positive and happier. And if you're this is something I would ask you to have a read off. So the psychophysiological effects of smiling. If you've got an attractive smile, quite often when we do a smile makeover, our patients can't stop smiling, and as a result, they're happier, because as soon as you start smiling, as soon as these muscles contract, okay, the body starts producing these neurotransmitters and these hormones, okay, and it makes you happier, it lifts you up, okay, whether you're smiling for no reason or whether you're smiling or laughing because Jin's really funny or the person you're talking to is really funny, the body starts producing the same sets of chemicals, and you can tell by Stephen's face, okay, just looks more uplifted and looks happier, and the reason is he is happier, physiologically speaking.
And here you can see the occlusal pictures. And this is a true case of minimally invasive aesthetic dentistry. Again, using the fast approach, but as we said, there's nothing fast about this treatment. This took me nearly 8-9 months, if not a year, to complete start to finish. From the trial to the whole mock-up stage, to the fitting, composites, the whole situation. And so the last check.
Jin, how long did it take you to do these composites?
I booked out 1 whole day for the uppers, 1 whole day for the lowers. That's the label composites. And then, again, I said to you, if you're going to do these cases, there's nothing fast about it for myself. I want to make sure it's predictable. And again, look, we're checking here the occlusion. So the red dots is our static ICP points, or the point contact. And then you can just about make out the red on the canines. If you look carefully, you can see the red on the canines. That is our excursion. So it's canine guidance. I'm checking. Is it canine guided on canines? And protrusion is slightly shared between the canines and incisors. So I'm triple checking, making sure it's all right. And that was the case afterwards. Again, direct composite bonding. Took me a whole day, and I'll recommend booking out enough time to get these cases done. And that was the whole case. So what we've shown to you guys: minimally invasive aesthetic dentistry, fast approach, function, aesthetic speech, trial. We've gone through terminology of occlusion. We've touched on the ACE classification. And again, I'll send it to Niji regarding this as well, on the case as well. And we've touched on different topics to get here as well. And this was 8 years ago. Everything is still in place. Nothing's chipped away. The only thing that's happened is, as it is composite, Steve's picked up a lot of staining on a couple of teeth. He's still smoking, still having coffee. So teeth have picked up staining. So the way I tell my patients about composite bonding, it's a bit like Botox. Every 6 months, every year, you will need a top up. So every 6 months, you'll need a refresh, polishing, every 6 months to a year or so. And that way patients are aware of what's going on as well. So what we're going to go through now is just a quick introduction of what we've been up to and how we got where we are. So I qualified at King's College London, the best dental university in London. Obviously, Manchester's good. I don't want to get you lot logging out already. And Ali qualified from here, Barts. I love showing this because you can see a lovely, skyline of London, the Shard. Obviously, the Shard wasn't there when I was at uni. And you've got Royal London. And Ali was such a esteemed student at Barts. We were there at the BDSA where we met Niji as well. And when I came out of my car, the first thing I saw, they've actually put a statue up commemorating Ali, which cracked me up a bit. They actually put a statue up of Ali. And yeah, they put a statue of Ali's head, the back of Ali's hair.
You're such a... Thank you, Jin.
Sorry, bro. Yeah. And the way myself and Ali met is through FD training. So Ali was the FD before me in practice. We both did our training in London Deanery, which was back then the Barnet Hospital, the Barnet scheme. And some of you may not know, it's quite a special scheme. It starts in January.
It's the most special scheme, not quite a special scheme. It was the most special scheme.
In the whole country.
Yeah.
So most of you guys know FD training starts in September. The Barnet scheme starts in January. So we'll go on to why we started in January. But Ali has been quite busy since he qualified. So Ali, do you want to go through what you've been up to, bro?
Yeah, absolutely. Since I've graduated, guys, I've taken an interest in lots of different things, but primarily been doing lots of teaching. And in recent years, I've taken an interest in hypnosis, and I'm now a neuro-linguistic programming practitioner. Neuro means brain, linguistic means language, programming means how you create an effect. So understanding how the brain works, how we can use our language to create an effect, okay? And hence I was talking about smiling because it's all about neurochemistry, and I've also, now in terms of my practice at the moment, done, teaching qualification, coaching and mentoring qualification, teach at the Royal College, and I've been teaching together with Jin now for 10 years. And I can't believe it's flown by, and it's definitely our favorite aspect of the job is to have the ability to teach and to have an FD, to be an educational supervisor. So currently I'm working in practice 3 days a week. I am a NHS clinical advisor so I'm a clinical advisor to NHS England, and sit on the recruitment panel for DFT training, do lots of things. And that's what I would say to you is the best thing about dentistry, okay, is the variety of stuff that you can do. Okay, you've got teaching, you've got advisor role, you've got medical legal stuff, you've got law, you've got business, you've got communication skills, you can become a specialist, you can go into business like Jin, you can do so much stuff. And I think it's such a versatile profession. It's amazing. And I'm glad that I am a dentist, and I wouldn't change my profession for anything. It's truly been a blessing for me. And like Jin said, you know, I did graduate from I was invited to stay back in dental school, is the polite way of putting it. Okay, I didn't finish on time, so I graduated in December and started in January, February. I did the extended BDS course. Okay, but it doesn't make a difference as long as you enjoy the journey, and that's the key thing. Not by any means, okay, was I the brightest spark of the dental school. Okay, and I mean, given how clever you guys are and you don't know what a FASPO is and centric relation is, I honestly couldn't answer these questions even 2-3 years out of uni. I just knew what it looked like. That's it. Didn't know what it was for.
So Ali was the FD before me in practice. So when I started my FD training, Ali had just finished. So he was an associate in the other surgery. So that's how we first met. And I've done very similar stuff to Ali. I mean, I've done a certificate in aesthetic dentistry in London and an MSc in restorative at Eastman. Spent 5 years there. And again, same as Ali, very passionate educator. Done a lot of education stuff. So PG Cert, dental education, leadership coaching. Again, myself and Ali, 8 years now on our 9th FD. Serena, who qualified from King's. And I'm a clinical lecturer at the Eastman on their MSc program, and with Ali at the Royal College of Surgeons. And again, same as Ali, I was never the most high flyer at uni. But again, with dentistry, it's such a beautiful profession. There's so much you can do. And since we've qualified, we're passionate about education. I've also gone on to build a brand with myself, Ali, Kish, and my brother, Smart Clinic Group. So we're about to close on our 10th practice. So we have 10 practices in the southeast of England. So I work in a mixed practice, but majority of my time is managing the group and the Smile Dental Academy. And this is our practice in Essex where we work, Waltham Abbey, Cobbins Brook, where it's an DFT practice. This is Ali's surgery. And again, everything we discussed and which I train, photography and all these things, we incorporate all this routinely in our practice. And I think it's super important to get our patients involved in the process as well with everything. Let's go to fast forward. And again, look, we've had a lot of opportunities over the years. Ali, this was in Dubai, right?
Yeah, absolutely. 3 years ago in Dubai, I was invited to give a lecture, and it was one of my first opportunities to teach at an international stage. And like I said, it's just been a pleasure, but it was a great holiday. That's the key thing, okay? So, I mean, this year, I think Jin and I, very likely, if we get invited. Jin, by the way, they've pushed the dates, so it's not in February because of COVID. It's now in July. So it'll be super hot. So yeah, if they tell us to go, that's where we're going. Just so you know. On that note, I just got the email for that.
And Ali loves this slide. Like myself and Ali, we work together, we train together, we teach together. Yet we are polar opposites in personality and clinical as well.
Yeah,
and that's the beauty of dentistry.
By the way, if you're wondering, I'm the short one. That's why he's made me. In real life, I'm shorter as well. I know you can't see it. I'm not that short, but Jin is just tall.
So, Brilliant. And as we were saying, look, none of this would have been possible if it wasn't for our FD.